السلام عليكم. يعطيكم العافية. Thank you, Prof. Juma. Actually, because he knows me, I thought he's talking about someone else. I would really like to thank the organizing committee, especially Dr. Lulu and Dr. Faisal, for my invitation to this outstanding meeting with all those knowledgeable people. I'm really excited to be here. Right. Because I know my moderator is very sharp in time, Prof. Juma. I will start with my slides soon. So, we're supposed to talk about SLD. SLD presented abstract about the topic that we're giving. I looked at the ASLD 25 and ASLD 24. Apparently, autoimmune hepatitis is an odd disease that people are not interested to look at. They're not studying it. In 2025, it's about 12 abstracts about autoimmune hepatitis, and the situation is not much better. I think the slide is too slow. In 2024, about 22 abstracts. Believe me, none of them was dealing with treatment of autoimmune hepatitis or de-escalating therapy, which is the task that was given for me by the organizing committee. So I tried to work it in another way. So who's the right patient to de-escalate therapy? When and how? Before I will move forward, I have one of my patients at AIH. She's 29-year-old Saudi lady with autoimmune hepatitis from the age of 18 years. She's in complete biochemical remission, normal ALT, normal IgG for more than 5 years. She had her first baby 3 years back, and she's doing fine. The baby's fine. Unfortunately, she gained weight after delivery. Her BMI now is 30, and she's maintaining 5 prednisolone and 100 azathioprine. Her FibroScan showed currently she's S2. She moved from S0 to S2, and she's F4, and she's maintaining her F4 about 16. I was trying to use the Mentimeter, but I know it's going to waste time. But how many of the audience, if you would raise hand, would try to give this patient chance of de-escalating therapy? If you could raise hand. Okay, not too many. That's good. So I don't think you need the presentation then. So the goals of treatment of autoimmune hepatitis is to maintain the remission, avoid flare, and to prevent the disease progression to decompensation and hepatocellular carcinoma. The reason that we attempt to reduce or stop the medication is the long-term toxicity of the medication that we're using, in particularly the prednisolone or the steroids. So de-escalation is the reduction of the dose of treatment of patients with autoimmune hepatitis, trying to withdraw the medication gradually. The rationale, as I mentioned, that we have to minimize the toxicity, in particular the steroids toxicity, and at the back of our mind, we have to always remember the treatment goals of autoimmune hepatitis. So patients who are in biochemical remission, so if you look at the box, the guidelines, everybody will tell you that patients in biochemical remission for more than 24 years, they might be candidate for trial of de-escalating therapy in autoimmune hepatitis. So biochemical remission is the normalization of the transaminases or the ALT and the serum IgG for more than 24 months. Moreover, patients who had liver biopsy and repeated liver biopsy, if they have stable histology or improved histology, and patients who are adherent to therapy, and patients who are regular in their follow-up, they might be candidate for de-escalation. However, looking at the side of the world, at the other side of the world, we have to consider the patient himself. We have to individualize the treatment or the de-escalation of treatment in patients with autoimmune hepatitis. So patients with advanced liver disease, they're not the good candidate for de-escalation. Patients who had patient on factor, that patient at the extreme of age, who had difficulty in compliance with the medication, they're not good candidate for de-escalation. Younger patients, they tend to have, especially pediatric, tend to have frequent relapses, so they're not good candidate for de-escalation. And the pattern of the disease itself, so autoimmune hepatitis with frequent relapses, those are not good candidates for de-escalation. And patients who had follow-up challenges. So in our country, some patients, they're coming from rural areas to Riyadh and Jeddah, and sometimes they're missing 1 or 2 or 3 appointments. Those are not good patients that you could stop their medication, and they only come back to you when they have jaundice. At the other hand, now we're in the era of mass LD, and patient with other liver disease, muscle disease, a pandemic that involving patient with autoimmune hepatitis and patient with other liver disease. We need to look at that carefully. And patient with other overlap autoimmune hepatitis, we need to look at the activity of the other disease. And patients with other systemic autoimmune disease where the immune system is active. Maybe they're not candidate for de-escalate therapy or they're having active immune system and that they're going to relapse. And we need to consider what other type of medication they're on for like patient with IBD, patient with rheumatoid arthritis. We need to look at the global view of the patient or the overall view of the patients. Patients who are pregnant, patients who did not finish their family planning, they're not good candidates for de-escalation because the disease can relapse during pregnancy. When we try to de-escalate, when we select the right patient, we have to go down gradually, starting with reducing the steroid over very slowly, 2.5 to 5 milligram over a couple of few weeks. And we follow the patients. Usually the follow-up has to be like every 4 to 2 weeks. But if I would do that, in the first few weeks, I'll see my patients like at least every 2 weeks. During the reduction of the steroid, the patient should be continued on azathioprine. And after stopping the steroid, all the literature will tell you keep the azathioprine the longer period that we could, and you reduce. Nobody will tell you when you can start reducing the azathioprine. So during the de-escalation of therapy, the patient should be monitored closely, as I mentioned, laboratory, and we have to teach the patient about the symptoms. So in case of new symptoms, the patient has to show up, and the patient should have easy accessibility to his physician or to the treating team. Patients who have been on early remission when they were first started on therapy, they're very likely to de-escalate it and to stop their medications. Patient who does not have previous relapses, patients with low normal IgG and ALT or transaminases, and patients who are in histological remission or patients with histological improvement, they are the candidate that could respond to de-escalation. In case of relapse, that's like the literature said that 50 to 80% of people, they might relapse. And sometimes some literature that showed even after 10 years, 100% of people, they could relapse. So we have to resume the immune suppression medication promptly, and we start with the previous effective dose. And those who relapses during de-escalation, they're not good candidates for giving other trials. So de-escalation, you could attempt that in the appropriate patients. Strict criteria that's not actually there, the literature. Relapse is common, and goal, you have to balance between the medication, de-escalation, and the side effects of the medication. The take-home message from this part of the lecture that we've been using the medication for more than 75 years. And we know those medications, they are quite safe in the good hand with the expert physician or the expert hepatologist. The other thing, this has to be individualized in the patient selection, and patients who should be, who are initiated on de-escalation of medication should be monitored and followed very closely. I'll move on to the other part. Right. This study by Harrison et al. In 2019, it's a good study that looked at, it was sort of meta-analysis for the studies of de-escalation of therapy in autoimmune hepatitis. When I look at that study, this study showed that relapse is almost universal, 50 to 80% of patients will relapse, and most of the relapse occur within 6 months to 12 months, and within 1 year, most of the patients that will relapse. Repeated relapses are associated with fibrosis progression, and sustained drug-free remission is almost very minimal, or only minority of patients could be achieved. Moreover, most of the withdrawal studies, they were before the 2014. And those studies showed they included a small cohort of patients, and the inclusion criteria or the selection criteria is not, it's just heterogeneous, especially in terms of IgG normality and ALT normality. And despite of those limitations of those studies, those are the ones used usually in the clinical guidelines. Biochemical remission does not always reflect histological remission, and stopping the therapy in high-risk patient expose the patient to recurrence of autoimmune hepatitis, repeated withdrawal. They're not good option, and that put the patient at risk of disease progression. And a long-term, low-dose maintenance therapy might be better for patients with autoimmune hepatitis rather than stopping the therapy. I'm from Jeddah, I like Jeddah. I know. That's the Jeddah, I think this is the way you have to look at autoimmune hepatitis. Right. Now, because we don't have new literature on autoimmune hepatitis, I tried to look at the EASL guidelines and the SLD guidelines, comparing both guidelines. EASL guidelines, they updated their guidelines recently in 2025, and it's more or less the same. Patient has to be on treatment for more than 3 years with complete biochemical remission for more than 24 months. With SLD guidelines, they put the histological remission from the previous guidelines. However, the EASL, they added the histological remission only this year. It was not recommended in the previous version of the guidelines. And both emphasize that we have to be very selective, individualize the selection of the patient. At the end of it, both guidelines emphasize that, especially the updated EASL guidelines, emphasize the high risk of relapse and no modern prospective study that address the disease, and both guidelines acknowledge the limited quality of the data that were included in the guidelines. Right. So the relapse risk, as I mentioned, usually within the first years, most of the patient will relapse, and each relapse is associated with disease progression. And the relapse risk was almost steady until the mid-2000s, until 2014. However, these are some of the studies that were used, the ASD, and these are some of the studies they were used for the EASL guidelines. Over the last few years from the COVID-19 and COVID-19 vaccine, we have seen a change in the pattern of autoimmune hepatitis and the relapse rate of autoimmune hepatitis. We have some patients who had relapse after 10 years while they're on treatment. So when we come to the guidelines, we still have guidelines, international guidelines gaps for the recommendation whom and when and how to de-escalate therapy in autoimmune hepatitis. After I mentioned about the era of the COVID vaccine, maybe the virus, maybe the vaccine itself, and most of the studies, there's a small number of patients and no modern studies that discuss these issues. Right, so relapse, as I mentioned, it's the rule. It's not an exception when you de-escalate therapy. We have to bear that in our mind. And it's common and clinically significant in some patients, especially high-risk patient or the inappropriate patient. Biochemical remission does not mean histological remission. Repeated relapses worsen the patient liver outcome and the patient outcome, and long-term. This is the second time I repeat, long-term, low-dose maintenance therapy may be safer than repeated withdrawal attempt in patients with autoimmune hepatitis. Avoid withdrawal in high-risk patients. This is in patient with other autoimmune disease. Please discuss the patient with the rheumatologist or the treating physician regarding the appropriate treatment for both autoimmune hepatitis and the other disease. Patient education and patient involvement is mandatory when you treat autoimmune hepatitis. I think Dr. Fahad has shown the non-invasive markers. None of the papers was addressing autoimmune hepatitis. So it's a disease that we don't look at in the era of mast cell and before in the era of viral hepatitis. We need to have criteria, which patient, how to de-escalate therapy. And maybe we'll go, if we go from immune suppression, avoiding steroids, to more immune modulation and more immune modulation therapy, that might improve the outcome of the patients. And patient education, discovering new biomarkers, and risk stratification of the patients might be the future direction of de-escalating therapy for autoimmune hepatitis. And I think I'm going to stop over here. And that's it.